Well, I want to thank you guys. This has been a fantastic discussion. I apologize that no one was passionate about the field in their discussions. But we present a lot of data, a lot of information. So last words to you, thoughts?
This is an extremely exciting time in B lineage ALL, the confluence of the use of the pediatric intensive regimens in young adults, the increasing use of minimal residual disease assessment to target patients who are at higher risk, and the promise of both immunotherapy and the small molecules really to me pose an exciting future and increasing benefit for our patients in a disease where we've been stalled in the adult setting for so many years.
Well, thank you. And from my perspective, one of the things that I take home from this is let's not be age biased. It doesn't make a difference if it's ped versus adolescent young adult versus the older adult, be it in AML or in ALL, and we need to be doing some more work on that. We need to make sure the adolescent young adult patient gets access to treatment that gives him the best chance of cure and long life. And we do want to challenge the MD Anderson folk to join us on a stage, Dr. Douer and myself. So I'm going to pass to Dr. Douer.
So I would put it a little bit historically, and about 150 years ago, they separated.
I wasn't born yet.
Yeah, me too. They separated between ALL, acute lymphoblastic leukemia, and acute myeloblastic leukemia based on microscopy. There was no cultures then, no cell cultures, no flow cytometry. It's interesting that they were right. The two separate diseases. And I think one thing, I don't think we should treat ALL like we treat AML. The concept of massive myelosuppression, discussed it. The non-myelosuppressive. So I think that's beginning to be recognized. And that's a concept that was established without the modern technology. And I think they were right. So that's the first thing. And then you have, of course, what is common. So I should say two main things. First, the breaking up into more homogeneous groups. I mean, it starts with APL, and it's more difficult in other diseases. APL was found by chance. APL is acute promyelocytic leukemia. So, but the Philadelphia-like is a step towards that direction. And the third thing, of course, is to find the new drugs that either with or some without chemotherapy. And here, every of these advances has a model that proves this. The Philadelphia using a tyrosine kinase inhibitor is extremely active, and we find so new drugs, new modalities. And then finally, as part of the new developments, is harnessing the patient's own immune system instead of using a donor's immune system.
Jeff, and we've reviewed a lot. Do you have any last thoughts on what we've been talking about?
I think that in AML, my main thought is that we need to get patients on clinical trials. And it's a relatively uncommon disease, and as a group in the United States, we need to do better, and that's how we advance the disease. There's really very few examples of situations, perhaps maybe with an APL patient, where I would not recommend a clinical trial, but in almost all other cases of AML, young and elderly, we need to move patients toward clinical trials, and we need to develop clinical trials based upon the new molecular data that are being generated in the new targets. So I can't overemphasize the importance of clinical trials for this patient population because the current therapies we have just aren't good enough by a long shot.
Thank you. Raoul?
Yeah, for me, I think the couple of highlights are using an intensified pediatric regimen in younger adults or adults. I think that's a big point, and we should. It doesn't matter what it is so far, and I think the verdict is out, but using one of those. Then incorporation of the new targeted therapies, blinatumomab or CD19 antibody or CD22, to see if we can get patients into longer remissions. Teasing out the subsets that drag down the curve, so we actually may get away without a transplant, and I think we will see those subgroups that have an 80-90% long-term overall survival rate without transplant. And MRD is important. I know it can be tricky and cumbersome to measure and send out the assay and find the lab if you're out there, if you don't have a large medical center, but we have to think about it, which brings me to the molecular markers and testing for those. We still see patients that don't have FLT3 testing done. And not because FLT3 is the target and it may just get away with the disease and cure the disease, but we can do something with it. And there are other molecular markers when you think about it, because it really helps us risk stratify today and then learn more, as you were saying, over the years, not just by the markers we have now, but then further dissecting the molecular subtypes. And we can only do this if we learn. And how do we learn? If we collect the samples from patients. Meaning we have to collect the samples, we have to commit to that as a community, not just in academic centers, but also in community centers. And we have to enroll patients on clinical trials. Otherwise, we will not learn from that. And it is exciting.
So one of the last things I want to state is we won't get to cure if we don't continue to do research. It's really important to think about putting patients on clinical trials. And another point is we need to get biobanking of these samples. We need these samples so that we can do this beautiful science that's been shown at the ASH 2014 meeting, and we continue. So on behalf of our panel, we want to thank you for joining us, and we hope that you found this peer exchange discussion to be useful and informative. Thank you.